Hello, welcome to Pathagonia. Hope y'all been doing well. We're gonna talk about melanocytic neoplasms using Kurt's notes. Before we begin, if you already haven't, check out Kurt's notes, the website. It's run by Dr. Schaberg and it's got great resources. All right, let's begin. So we're in for a treat. This is a relatively new Kurt's notes, updated September 23rd. So, melanocytes stained with S100, SOX10, HMB45, Melan A or marked 1, and MIT F. These aren't necessarily specific in isolation. For instance, S100 stains nerves, Langerhans cells, fat. HMB45 and Melan A can stain pigment in keratinocytes. And MIT F can stain histiocytes. So let's talk about benign lesions, freckles. These are red-brown macules in sun-exposed areas, and there won't be elongation of reedy ridges or nesting. You don't see these elongated reedy ridges. You just see increased melanin in the basal layer. And it's common in fairer skinned individuals. I wish I had freckles, but I don't have as many. Café au lait spots. This is French for coffee with milk. As you can see here, clinically it's a large light brown macule, and microscopically you'll have increased melanin in the basal layer, but otherwise normal. Histologically, it's very similar to freckles, and it's sometimes associated with NF1. And if this smooth oval border were irregular, like looking like the coast of Maine, consider McCune-Albright syndrome, which is a GNAS mutation, and it's in addition to café au lait spots, you'll have polyendogranopathies as well as polyastotic fibrous dysplasia. All right, lentigo simplex. You know how freckles we talked about, there's no significant reedy ridges? Well, in lentigo simplex, you'll often have elongated reedy ridges with hyperpigmented basal layer. There won't be melanocytic nests, no solar elastosis, because this clinically occurs in children and adolescents. So it's not related to sun exposure. It's relatively small, less than 5 millimeters, and especially on the dorsal forearms. And if there are nests involved, it would be a junctional melanocytic nevus, not a lentigo simplex. All right, one of my favorite benign entities is solar lentigo. These, as you can see the solar elastosis here, these happen in older individuals. And you'll have these hyperpigmented basal layer with clubbed, elongated reedy ridges. Dr. Schaberg says 30 feet, and kind of related on that note, our residency talks about like puppy feet. Especially those with kind of brown fur on their feet. And these are common on the face and dorsal hands. All right, now let's go to the nevus, melanocytic nevus. Nevus, just as an aside, means a hamartoma. And you can have adipocytic nevi, you can have melanocytic nevi. So when you say nevus, it's not necessarily melanocytes, although we typically associate nevus with melanocytes. All right, let's go back. It's a benign localized proliferation of nevus cells, a type of melanocytes, and it's defined by the presence of nests, which you need a clusters of at least 3 cells. So here are some nests here. And they're clinically small, usually less than 5 millimeters, well circumscribed, symmetrical. That's very important to distinguish from atypical or melanoma. Evenly colored. They can be found all over, and they can be acquired, quote unquote, and grow during childhood. And it's most common with light skin. Frequently, they have a BRAF V600E mutation. Here, we see nests in the epidermal-dermal junction. Therefore, it's called a junctional nevus. Here, we see nests at the junction, dermal-epidermal junction, but we also see nests at the papillary dermis. Hence, it's called a compound nevus. And then here we only see melanocytes in the dermis, and so this is an intradermal nevus. We have to know normal histology in order to differentiate it from atypical nevi, melanocytic nevi, and melanoma. And some reassuring histologic features are small size, less than 5 millimeters, symmetrical, well circumscribed, nested at the DEJ, regular size and distribution of nests, bland cytology, and no dermal mites. In addition, there should be maturation. What that means is, in part A, like closer to the papillary dermis, you'll see epithelioid melanocytes. B, you'll see lymphocyte-like melanocytes. And C, you'll see spindled or neural-like melanocytes. So here you see the epithelioid melanocytes. You see more, there's only like that telltale rim of cytoplasm as you see in lymphocytes, kind of lymphocytic-like melanocytes, and then you'll have these spindled or neurotized melanocytes. And then let's just talk about variants. You can see these in other instances too. I've seen them in endometrial biopsy that they have balloon cell change. Well, in that kind of same note, you can have a balloon cell nevus, which has abundant clear foamy cytoplasm with small central nucleus. So just don't be scared when you see this. Although if the patient has a history of, I don't know, like VHL and clear cell renal cell carcinoma, and it's has a lot of vessels, you also want to think about metastasis from clear cell renal cell, but it would be more atypical. Anyway, then you could have the neuro or neurotized nevus, and this is, remember those type C cells? They will predominate, and your differential would include a neurofibroma. All right, now that we talked about the benign features of a melanocytic nevus, let's talk about dysplastic nevus. So these are benign, ultimately melanocytic nevi that is clinically atypical and has some architectural disorder and cytologic atypia. It has some features of melanoma, but still benign, and it is a risk factor for melanoma. All right, let's first talk about, I love how Dr. Schaberg organizes this. First, architectural disorder and cytologic atypia. Let's talk about architectural changes. Remember how we said smaller, like less than 5 millimeters of a nevus is reassuring? So larger size, greater than 4 millimeters or so. You'll also want to, architectural changes include shouldering. And what does that mean? That means your junctional component, the melanocytes in the dermal epidermal junction extend beyond the dermal component. You'll have lentiginous hyperplasia of the melanocytes. You'll have bridging of melanocytes of adjacent reedy ridges. You'll have concentric and lamellar fibroplasia around the elongated reedy ridges, as you can see here, as well as here. And you can see patchy lymphocytic infiltrate. The lymphocytes know that there's something weird going on, and so you can see them react oftentimes. So cytologic atypia, you'll have nuclear enlargement and your reference cell is your basal keratinocytes, hyperchromasia, prominent nucleoli, and that gray dusty kind of melanin that you'll see. So in terms of differentiating nevi from melanoma, you can use some stains to help you. It's not 100% slam dunk, but in the grand scheme of things, along with the histologic features and the clinical history, it can help persuade you if it's malignant or not. So nevi, Ki67 is less than 2%, melanoma is greater than 10%. HMB45 gets lost as the melanocytes mature, as they go down deeper to the dermal layer. That's why nevi, it's positive at the superficial layer, because the nevi mature and you lose HMB45. However, melanoma is all throughout the tumor. P16 will be intact, P16 will be lost in melanoma, and then PRAME will be negative or focal in a nevi and diffuse in a melanoma. And then just remember your A, B, C, D, E clinically as well for melanoma. And one thing that's really cool about DermPath is there's a lot of interplay between the clinical history and the pathology. All right, I want you to go over this on your own time, but just key things about differentiating no atypia or mild atypia, moderate atypia in a nevus, high-grade dysplastic nevus, or melanoma. First of all, these are very hard, especially amongst even the moderate to mild or moderate to severe. There's a lot of discrepancy, and in our case, we have consensus conference 2, and a lot of those cases are to help differentiate whether moderate is severe or moderate is mild. And just things I want to point out is size. High-grade dysplasia, moderate grade dysplasia will be greater than or equal to 4 millimeters. Symmetry. So if there's asymmetry, then you want to think about high-grade dysplasia or melanoma. And then, oh yeah, pagetoid spread. If there is extensive pagetoid spread, you want to think melanoma. However, it's important to note that there are benign things that are also do have pagetoid spread, such as special nevi or like acral nevi, which we'll come into in a bit. Maturation, melanoma has absent maturation. And nucleoli, you'll have prominent nucleoli and often lavender shaped, colored in melanoma. Okay. Now, just if you can go over that on your own time, that'd be great. Now, let's talk about Spitz nevus. This is named after Dr. Sophie Spitz, who made a clinical case series of these. It looks scary. It's a classic mimic of melanoma, but your clinical hint would be these patients are often young. It's a tan papule on the upper body head, usually less than 6 millimeters. They're enlarged epithelioid and can be spindled melanocytes. There's no significant cytologic atypia, no deep mitoses. It'll be symmetric. You'll often see this clefting, as you can see here. And it'll have epidermal hyperplasia and these melanocytes that have vertical nests. One of my staff calls it like raining chocolate bananas or something, or raining bananas. And in addition to these raining down vertical nests, you'll have maturation of dermal melanocytes, and you'll have caminobodies, which are eosinophilic globules. So this will be a great hint for you. So make sure to look for these when you're suspecting Spitz nevus. And they may have focal pagetoid spread centrally. So here's another instance of a benign entity that can have pagetoid spread. If you're unsure, you can get an IHC and you'll have P16 will be retained. Remember, it'll be lost in melanoma. HMB45 will only be positive in the upper dermis because as the melanocytes mature, which happens in Spitz nevus, they'll lose HMB45 expression. And Ki67 will be less than 5 to 10%. However, that being said, you know how nothing in pathology is always easy? Well, you can have a spitzoid melanoma, and you want to suspect that, especially if the patient's older. The lesion is larger than 10 millimeters. There are significant mites, ulceration, fat invasion, asymmetry, poor circumscription, diminished maturation, or diffuse pagetoid spread. And I love this phrase that Dr. Schaberg wrote. especially if you're unsure about melanocytic lesions, and it's even among derm paths that I've seen, there also have to do consensus. Always carpool to court. So ask your colleagues. Okay. You know how we talked about the Spitz nevus? We talked about Spitz melanoma. Well, in between you have a Spitz melanocytoma, which is an atypical Spitz tumor. And I also want you to read this on your own time. The only thing I want to mention is for melanocytoma and Spitz melanoma, melanocytoma will be often greater than 5 to 10 millimeters. Spitz melanoma oftentimes greater than 10 millimeters. You'll have well or poorly circumscribed, and the Spitz melanoma is often poorly circumscribed. And then in terms of mites, you'll have 2 to 6 or more dermal mites, and then Spitz melanoma, you'll often have greater than 6 dermal mites. But yeah, please go over this at your own time. All right, now let's talk about blue nevus. This is, from afar, you can see the color, the hyperpigmentation here. And you can see how much pigment there is and how that can explain this kind of bluish black clinical picture here. And it's a dermal proliferation of dendritic, spindle, and/or ovoid melanocytes associated with melanin pigment and melanocytes and melanophages, and you'll have this stromal sclerosis. And then a cellular blue nevi is a well-circumscribed cellular bulbous vertical extension of the lesion into the subcutaneous adipose tissue, pigment in mostly melanophages. For blue nevus, you want to remember, you know how we said at HMB45, melanocytes lose it as they mature? Well, blue nevus is a benign entity that has HMB45 positivity throughout. So it's important to know that. Okay, congenital melanocytic nevus. When I first got these were really scary looking. Like, your key to knowing how this is a congenital melanocytic nevus is clinically they present at birth. It can be quite large. They have this deep dermal involvement, splaying of collagen, angiotropism, but you want to, at least the hint for me, is this infiltration of appendageal structures. So that's been a really good hint for congenital melanocytic nevus. Most have NRAS mutations and can develop a proliferative nodule, and even rarely melanoma. All right, let's talk about the pigmented spindle cell nevus, aka reed nevus. It's a subtype of Spitz nevus, and it's heavily pigmented spindled melanocytes involving the epidermis and superficial dermis. You'll have epidermal hyperplasia and clefting spaces, just like your regular Spitz nevi. Pagetoid spread is common, usually in the lower central epidermis, and you'll have many melanophages. They should be symmetrical with lateral circumscription, and usually clinically it'll present as a small dark macule or papule that's approximately 3 millimeters, and the patient population who get these reed nevus is younger females on the lower body. Okay. Special site nevus. So these nevi look a little bit weirder compared to your just normal benign nevi. And it's important to note special site nevus so that if you do see them and it's at that special site, you can have a higher degree of suspicion. So the special sites include the breast, axilla, think about your flexural sites, your scalp, ear, umbilicus, genital skin, and acral skin. And it's important to know because it can sometimes make reliable distinction from melanoma difficult. And it's unclear why these special site nevi have a little bit more atypia, but it's thought to be maybe due to trauma, friction, hormones, UV. And as Dr. Schaberg says, the most important thing is to recognize this site when the dermatologist tells you where they biopsied the nevus, and have a higher degree of suspicion, allow more leniency with atypia before diagnosing a lesion as melanoma. Remember, atypical histologic findings include asymmetry, architectural disorder with an irregular arrangement of the junctional melanocytic nests, cytologic atypia, pagetoid spread, dermal fibroplasia, and a lymphocytic infiltrate. And you shouldn't see increased mites, individual necrotic melanocytes, and there will be preserved maturation with descent into the dermis, unless it's actually melanoma. Okay, let's talk about other variants of nevi. Halo nevus. This has clinically a circumferential depigmentation. Histologically, you'll see a brisk lymphocytic infiltrate. Nevus spilus, sorry if I'm pronouncing it wrong. It presents as a patch of hyperpigmented skin. It has a variable number of darkly pigmented macules and papules, kind of like you spilled some drink. Mersenne nevus have superimposed eczematous dermatitis characterized histologically by spongiosis, and you can have associated superficial perivascular chronic inflammation and acanthosis. Ooh, recurrent nevus, I don't like these. You'll see, but the key to kind of differentiating this from an atypical nevus is you'll see junctional melanocytes, and they'll proliferate over a scar with this horizontal collagen fibers and myofibroblasts, and underneath you'll see bland dermal melanocytes. Nevus of Ido or Oda, these are dermal melanocytoses on the shoulders and arms or on the face, respectively. And then your congenital dermal melanocytosis, otherwise known as Mongolian spot. It'll be a bluish patch on the lumbosacral skin and other parts of the body. I've had this when I was a child. And on histology, you'll see single pigmented dendritic melanocytes haphazardly dispersed in the dermis, and they often regress. All right, we're almost there. Melanocytomas. These are all very rare, therefore low yield for boards, but it's that in-between category between benign and frank malignancy. It's like uncertain malignant potential, but usually benign. We talked about the Spitz melanocytoma. You can have a Wnt activated deep penetrating plexiform melanocytoma, pigmented epithelioid melanocytoma, and BAP1 or BAPoma, BAP1 inactivated melanocytoma, and a MIT-F pathway activated melanocytic tumor. I'll for those very interested or interested in going into DermPath, definitely read this slide. All right. Dun dun dun. Melanoma. These are, you don't want to miss melanoma. And the thing I find fascinating about melanoma is whenever you have a tumor of uncertain origin, you can always, if the staff asks you what the differential is, you can always say melanoma and you won't be wrong because it's a mimicker of a lot of things. But let's just talk about melanoma at the primary site primarily. So this is defined by cytologically atypical melanocytes and or architectural abnormalities. So let's talk about atypical melanocytes, what that means. And we kind of hinted at it or talked about it when we differentiated severe dysplastic nevus from a melanoma. You'll have large nuclei, prominent cherry red, lavender nucleoli, irregular clumped or dense chromatin, and eosinophilic or lightly pigmented cytoplasm. Sometimes they can be multinucleated as well. On architectural abnormalities, again, you'll have asymmetry. You'll have poorly defined borders. You think it stops, but it just keeps going. lack of maturation with dermal descent. You just like kind of reminds me of H cell, where the top cells look like the bottom cells. You'll have deep mitoses, pagetoid spread, epidermal consumption, and lack of dermal nesting because there's just sheets of melanocytes. So let's talk about MIS versus invasive melanoma. Melanoma in situ, MIS, is confined to the epidermis and dermal-epidermal junction, and includes some variants of melanoma, includes some superficial spreading and lentigal maligna. And then invasive melanoma extends into the dermis. And then there are two types of growth phases melanoma exhibits. One is this radial growth phase, where it expands horizontally in the epidermis and superficial dermis, and it's better prognosis at this stage because there's not a lot of lymph vessels, and it includes superficial spreading melanoma and lentigal maligna. I'm sorry if it's lentigo maligna, and then vertical growth phase. This is deeper expansile invasion through the dermis, includes like nodular melanoma, and this has a worse prognosis because once it goes into the lymphatics or vasculature, it can spread to other parts of the body. Okay, let's talk about development pathways. So there's melanoma arising in sun-exposed skin, and within that sun-exposed skin arising melanomas, you can have low cumulative sun damage, like your younger age who likes to tan a lot. Nevi and dysplastic nevi are precursors and risk factors. They frequently have the BRAF V600E mutations, and they have this high mutational burden, which is you have the CT point mutations, and that's arises from that UV signature, and it gives rise to superficial spreading melanoma and a subset of nodular melanoma. Okay, and then you have your high cumulative sun damage. Person who works outside in the sun all the time, doesn't wear sunscreen. They're older age, their skin looks like leather. This can originate from melanoma in situ and a mutually exclusive NF1, NRAS, KIT, and non-V600E BRAF mutations. And they have a very high mutational burden. And this gives rise to lentigo maligna or lentigo maligna, a desmoplastic melanoma, and a subset of nodular melanomas. Okay, let's talk about melanoma arising in sun-shielded skin, where there's no UV association. So this can occur in acral sites, mucosal sites, uveal sites, and melanoma arising in a congenital or blue nevi. Some genes mutated are TERT promoter and CDKN2A. And then patterns of growth of melanoma include pagetoid pattern, where you'll have those buckshot, so to speak, cells in the epidermis, and you'll have this lentiginous pattern where they grow along the DEJ without pagetoid scatter and fewer nests. Okay, I'm sure you'll get this on your boards or your practice exams, but prognosis depends on the depth of invasion. More so than ulceration, mitoses, LVI. And that's measured oftentimes by the Breslow thickness, which is measured from the granular layer of the epidermis to the deepest point. All right, now let's talk about the different variants of melanoma. You have your superficial spreading melanoma. This is low cumulative sun damage melanoma. You'll have these pagetoid and or lentiginous intraepidermal atypical melanocytes. Usually they grow in the radial growth phase, and if it's confined to the epidermis and the dermal-epidermal junction, it's MIS. If it extends to the dermis, then it's invasive melanoma. The intraepidermal component often extends greater than 3 reedy ridges beyond the invasive component. It's associated with benign nevus in 1/2 of cases, and it cannot be on the palmar or plantar surfaces. Okay, lentigo maligna. This is high cumulative sun damage. You'll have severe solar elastosis, frequently the head or the neck of the elderly. You'll have lentiginous proliferation of mostly single cells. There won't be prominent nests, and it'll be along the base of the epidermis. There'll be less pagetoid spread because it's kind of a lentiginous growth. And there's no precursor nevus majority of the time, and the epidermis is often thin and atrophic, and it can extend down adnexal structures. And it has that radial growth phase before developing invasion or metastasis. All right, nodular melanoma. This is melanoma in the vertical growth phase without an appreciable radial growth phase. It's not a distinct entity, but a manifestation of its acceleration of melanomas of multiple pathways, including low and high cumulative sun damage and acral melanoma. They can grow oftentimes rapidly and leading to ulceration and bleeding. All right, your acral melanoma. This is one of your non-UV mediated melanomas and has a low tumor mutational burden. It's most common melanoma in people with darker skin types and worse prognosis than similar stage tumors at other sites. Oh man, if you talk about scary, this is as scary as it gets. This and signet ring carcinoma, among other very scary entities. And it's already past Halloween, but it's not a holiday. This is actually a lesion that you do not want to miss. Desmoplastic melanoma. As Dr. Schaberg says, very sneaky, very subtle. You want to have a high index of suspicion. You'll have these spindled melanocytes that resemble fibroblasts between collagen fibers. It's off your kind of contextual histologic context clues are adjacent severe solar elastosis and atrophic thin epidermis. You can have adjacent lentigo maligna. And another context clue is these characteristic adjacent cannonball lymphocytes or plasma cells and frequent neurotropism. On IHC, they will be negative for HMB45. You know how we said HMB45 will be negative as melanocytes mature? Well, this is one of the exceptions. It's a melanoma, but it's negative for HMB45, negative for melon A. However, it will be positive for S100 and SOX10. Clinically, often appears as an indurated plaque, and it's oftentimes in the head and neck of elderly. All right, we talked about Spitz melanoma before, so I'll just kind of pass by that. Mucosal melanomas, it can arise in the anogenital, oral, and sinonasal mucosa. Especially in the GI tract, you want to exclude a metastasis from a cutaneous melanoma. And an in situ lentiginous component may be present and supports a mucosal primary and generally aggressive. This is also very scary. When you're looking at benign nevi, you always want to have in the back of your mind, could this benign nevi actually be a nevoid melanoma? It's not a distinct molecular entity, but it's a melanoma that resembles a melanocytic nevus. You want to look for atypia and mites deep at the high power. Often the nest runs horizontally to the surface, and you'll see loss of P16 staining, and they'll have supportive molecular data like CDKN2A loss, TERT promoter mutation. And one of my staff calls this, there's an episode of Seinfeld with this guy with a puffy jacket, and she told me that this kind of gives you that puffy shirt sign, that puffy jacket sign. These nevoid melanomas will be kind of very puffy, so to speak. They'll have, and that'll give you your low power clue, and then as you look closer, you'll see that atypia and mites at the deep level. I don't know the character from Seinfeld, so if you know, let me know. Okay, dermal melanoma. So this is rare. I saw this once at a practice case from ASDP conference this year. This is a primary melanoma limited to the dermis and subcutis without intraepidermal involvement. This is a diagnosis of exclusion because could this have been at a prior site? Could this have been a METS from a prior melanoma that has kind of regressed. So again, it's a diagnosis of exclusion. And lastly, your metastatic melanoma to the skin has spread from a primary melanoma to the skin. The primary may be occult or regressed. They can involve the epidermis and simulate an in situ lesion and or new primary. And the most common presentation is a solitary pigmented dermal nodule. Satellite metastasis is when it is within 2 centimeters of the primary, and in-transit metastasis is greater than 2 centimeters from the primary en route to the regional lymph node basis. All right. Well, thank you so much for listening, and we'll keep you in tune for the next episode of Pathagonia. Bye.